Thank you. So, managing complications and challenging situations of phakic IOL. I don't have any financial interest. ICL technique has been beautifully depicted by Dr. Partha Vishwas. Sometimes during the procedure, you come across with some unfolding issues. As you can see on the picture on the left, the ICL, when you are unfolding, it's not going proper. And we have to open it on the surface. And sometimes the part of the haptic, as you can see, the patient has squeezed the eye, the lens is folded yet, and it is not completely unfolded because the haptics are still in the incision. So what we do is we can push some viscoelastic inside, wait for a while, slowly, as you can see here, the lens start opening up. Or you can go through the side port, and something like the same is happened in this case on the right side also. The lens is being opened up, and it's not fully opened on the surface of the iris, and it's still folded. So you can push it from the side port, wait for a while, just nudge it and it will open up easily. So don't get panicked if such situation occur. And in certain situation where the lens open up outside the eye, so nothing to be like in this particular case, the patient squeeze the eye, move the head, and the lens which is slightly, partly out of the haptic, you just open it, and in the vial in which it comes, wash it through with the BSS and reload it on the same cartridge and same injector system and place it inside, as you can see here. So this can happen. It's easy to do it. Then there is an issue of removal of the viscoelastic, because viscoelastic remains underneath the lens when we have used it. And initially, in all cases, I recommend, and I also do it through the with the presence of viscoelastic. So if the viscoelastic which is present behind the lens, it is difficult to bring out. So what I do is I use the central opening, and with this aspiration port, I aspirate the viscoelastic from behind. Then rotation of the lens. The lens which is usually placed in a horizontal meridian. I am sitting temporally. The lens is ideally placed in a horizontal meridian, maybe 23 or 28 degrees on either side. This is the marking of the ICL usually. But in this particular case, it is oriented in a vertical meridian, as you can see. So it is easy because of the undersized lens. This has happened. The lens is rotated, and had it been a non-toric IOL, you can leave it as such. But this was a toric IOL, so patient's quality of vision deteriorated. So what is required is they just nudge the lens, go through the side port, bring one haptic anterior to the iris. With the viscoelastic cannula, you can do it without touching the crystalline lens, and hold the lens with the coin-shaped forceps, which is provided by the which we pull the lens and we load the lens in the cartridge, and you can easily pull out the lens. It folds on itself like a funnel, and it comes out through the same 3 millimeter incision, 2.8 millimeter or 3 millimeter incision, and another lens which is of a different size, which has been ordered. This can be placed inside the eye. The eye remains quiet and used, and what we have seen is that there is no chance of development of cataract unless until you have damaged the lens, crystalline lens, during the removal. So it can be done. Cataract is an issue, but formation of cataract is when the IOL vaulting is low. If it is less than 52 micron, then chances of development of cataract are more, or when the age which we have selected is more than 40 years or 45 years, and when there is a pre-operative spherical equivalent which is greater than minus 14 diopters. But with new center of flow design, the cataract formation is low because the metabolic alterations which occurs in the lens, which it doesn't get nutrition because of the movement of the clear or free aqueous flow, the metabolic alteration is not there, and the development of anterior subcapsular cataract is very uncommonly seen nowadays. and but we have to address the surgically induced damage to the lens capsule, but that has to be avoided. And in this particular case, because in my case there is a less vault, hardly any vault is visible, and there is a development of anterior subcapsular cataract. In this particular case, you can see in a pentacam image. And post IPCL cataract surgery is the last thing which I would like to share with you. And most of the complications are not there. So just remove the lens. This is a IPCL, and hold it with the McPherson forceps or any plain forceps, and fold it on the within the wound itself, pull it out, and then you can do the surgery as your technique is by any means. These are soft cataracts, but because it was central and it was quite dense, the patient, and it was covering the pupillary area, patient vision was very, patient didn't have good vision with the during the bright light or during sunlight, and while driving the patient was having uncomfort. So which we did by doing a cataract surgery in this particular case. So this is something different which I would like to share. It appears to be like a cataract, the post ICL picture of the patient, and it was sent to the patient was asked me sent to me, wherein I found that it is the central presence of viscoelastic which is retained behind the lens. It has not been properly removed, and it causes the image of which got emulsified, and it caused an image like the development of cataract on the day one of the surgery, post-operative period. So what I did was I asked him to be there, and I dilated the pupil and gave him some timolol maleate, something like that, and waited for, and steroid drops, and waited for 15 days. Everything disappeared, and I kept the patient dilated for this. So retained viscoelastic is one thing which can mimic the cataract. And this is one interesting case. A doctor, he developed an injury, had an injury post IL surgery done a few years back, and he came to me 2 years back with this kind of a picture. The IOL haptic has dislodged in the anterior chamber. One IOL haptic has come out, as you can see very easily here. So this he developed an injury by the handle of the motorbike, and this is how we just made two side ports, pushed the viscoelastic, and tucked the haptic behind the iris after dilatation. It is so simple, and he is still very good after this simple procedure. I did it on the same day, and I'm removing the viscoelastic, and since then it has been almost 3 years now, and since then he is happy. So last cases of the flipped IOL. Sometimes this is a case from another surgeon who sent the patient to me. The IOL was flipped. So instead of the lens vault, which should be anterior, the lens was touching behind. So anterior chamber was shallow peripherally. So this is one way we can manage the case. We filled the chamber with viscoelastic. Fortunately, the anterior chamber was deep enough, and we just flipped it inside the chamber. Other way is to remove the lens and replace it with another lens, or maybe if it is not damaged, then you can make a roomy opening and you can place the same lens, or maybe you can exchange with another lens by explanting it and then reimplanting it, or maybe you can do a rotation inside. And with this, I thank you all.